topic to all mental health service providers and social service providers, mental health assessments for unaccompanied minors in the U.S. I am Dr. Christine Miranda moderating today's webinar. We will also have Dr. Kerry Evans in the Q&A session. Please keep your questions short and to the topics of the presenter's topic. At the end of the webinar, we will have an open Q&A. Please use the question function on your screen to pose your questions. The webinar that you will be participating today is intended to provide you with additional knowledge and skills to help manage and serve unaccompanied children in your communities. The National Hispanic and Latino MATTC network uses affirming, respectful, and recovery-oriented languages in all our activities. The presentation was prepared for the National Hispanic and Latino Mental Health Technology Transfer Center under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. All materials appearing in this presentation, except that taken directly from copyright sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. Do not reproduce or distribute this presentation for a fee without specific written authorization for the National Hispanic and Latino MATTC. This presentation will be recorded and posted in our website. Okay, let's get started. Please welcome Dr. Rob Hassan.
Good afternoon, everyone, and hello. My name is Rob Hassan, and I'm an assistant professor of social work at Providence College. And today I'm going to be speaking with you about some strategies for mental health assessment with unaccompanied minors. So my research broadly focuses on the intersection of child welfare and immigration. And what I do specifically is I try to examine mental health risk and protective factors for unaccompanied children who have experienced forced migration. So my research, what I try to do is I try to inform the development of clinical interventions and policies that serve children and adolescents who are exposed to trauma due to forced migration. I'm also a clinician by training, a clinical social worker, and I've been in private practice for several years using different assessment frameworks to identify the needs of vulnerable children and youth. It's a joy to be with you today, and I'm looking forward to the webinar and the Q&A that we'll have towards the end. Today, I don't have any conflicts to disclose with you regarding my webinar talk. So I wanted to explain, to begin, some of our learning objectives. So we're going to be focusing on 3 objectives. Number 1, you'll learn how mental health assessment has been used in research to understand the complex psychosocial needs of unaccompanied minors. Number 2, you will learn about assessment strategies that can help identify complex mental health needs of unaccompanied minors. And then finally, I'm going to introduce to you the Strengths and Difficulties Questionnaire, or the SDQ. And you'll learn how that measure can help identify symptoms of psychosocial distress and prosocial behavior that unaccompanied minors may experience. These 3 objectives, we're going to try to address each of these within about 45 minutes, and that will leave 10 to 15 minutes of question and answer period. My colleague, Dr. Evans, will be supporting me with answering those questions. So you can go ahead and use the question feature on the webinar as I'm presenting the material. So to begin, I wanted to start with a definition of unaccompanied children, just to provide us with some background on this unique and vulnerable population of immigrants here in the United States. The official US government designation for this population is an unaccompanied alien child. So that's how the US government classifies and defines this population. They're further defined as one who has no lawful immigration status in the United States, has not attained 18 years of age, and with respect to whom, 1, there is no parent or legal guardian in the United States, or 2, no parent or legal guardian in the United States is available to provide care and physical custody. So before I begin, I really wanted to focus in on how this population is classified and defined by the US government. And in my scholarship, in my writing, and in my speaking with you today, I'll be removing this word alien from this definition. So I'm a social worker by training, and the word alien conflicts with various social work ethical principles, among them the dignity and worth of the person. So we find as social workers that alien is a particularly dehumanizing way to view this population. So I'll be removing alien from this classification, and today I'll be referring to this population as unaccompanied children, or UC. I use unaccompanied children and unaccompanied minors interchangeably. Some additional information. I think it's also important to understand the scope of this issue here in the United States, and one way to do so is to examine the numbers of unaccompanied children who have been arriving to the US border. As we can see from this chart, there's been a steady increase in the numbers of unaccompanied children arriving to the US since 2012, and this reached a peak of 69,488 in the year 2019. We saw a substantial decrease in 2020, and then recent numbers for 2021 are indicating that there is a rise again of unaccompanied minors coming to the US border, although we're still evaluating that data and it's ongoing. Some additional basic demographic information. What we know for unaccompanied children who arrived to the US border in 2020 are different features of their background, including age and country of origin. The data that I'm presenting here is from 2020, and what we know is that the majority of unaccompanied children apprehended at the US border were 15 to 16 years old. That comprised 37% of all unaccompanied children, followed closely by unaccompanied children who were 17 years old. So right away, we know that this population is in their middle teenage years. And we also know where they're coming from. So the pie chart on the right also depicts the countries of origin for unaccompanied children arriving to the US border. And in 2020, the overwhelming majority arrived from El Salvador, Guatemala, and Honduras, 3 Central American countries. And nearly half, 48%, arrived from Guatemala. And that was followed by a quarter, or 1 in 4, arriving from Honduras. This data from 2020 aligns with what we've seen in recent years. So we see a trend where the majority are arriving from Guatemala, about half, and then the majority from those 3 Central American countries. So this animation is depicting common migration routes that unaccompanied children are taking as they arrive to the US border. What this figure is depicting are the various routes that they take, and it also helps explain the various transportation methods that unaccompanied children are using during their journey, including buses, cars, sometimes riding on trains, and then, of course, when they get closer to the border, walking to the US border and sometimes crossing different bodies of water. So I also think that this graph, which I draw from UNICEF, is also depicting the scope and length of the journey, which helps us understand the various adversities that unaccompanied children may be experiencing during their migration to the US. We know from research that there are various reasons that unaccompanied children are migrating to the United States. Chief among them are poverty, violence, and family reunification. So unaccompanied children who are arriving to the US, we know that in El Salvador, Guatemala, and Honduras, research indicates that those 3 countries have low GDP, widespread poverty and destitution is one influencing factor for their migration to the United States. We also know that some of these countries, for example, El Salvador and Honduras, have widespread community violence and gang violence that is also a reason for migrating to the US. And then finally, we know from research that unaccompanied children are reporting that they are arriving to the US to reunify with family that is here in the US. And we've seen this amplified by recent news stories in recent weeks, more and more numbers of unaccompanied minors coming to reunify with their families and caregivers. So now that we have some basic background information, I think it's important to talk about the main topic for today, which is mental health assessment. So I wanted to begin with just a basic definition of what mental health assessment is and then we'll talk about some specific features of it that might be helpful for you and your work. So to begin, assessment is defined as an ongoing information gathering and decision-making process to help clients identify their goals, strengths, and challenges. It is a way for us to accompany and be in conversation with others to learn about what animates them, how they define their hopes, their dreams, their strengths, and then also help them articulate and identify their challenges. This process assessment is completed in collaboration with our clients, and the foundation of this assessment is the relationship that we build with clients. Data during assessment is gathered in various ways, verbally, non-verbally, and also at times with other members of the client system, for example, family or perhaps teachers or other professionals in their life. So data being gathered verbally, that happens in the context of conversation and discussion directly with the client. Non-verbal data collection happens based on our observation. Are we observing that the minor is having difficulty paying attention? Or are they having a difficult time maintaining eye contact? Are they fidgety? Do they seem hyperactive at times? That's all based on non-verbal observation. Oftentimes, collaborating and connecting with members of a minor's system, such as their family, can be particularly helpful. But of note, oftentimes when we're encountering minors, they are not with their family at that time, and they may not have close connections with teachers or other systems in their life. A final dimension of mental health assessment is that it may involve standardized measures of health and mental health. One of these is the Strengths and Difficulties Questionnaire, which I'll be explaining to you a little bit further this afternoon. Trauma-informed assessment is one lens that we can use as helpers to encounter and accompany individuals who are in need. And trauma-informed assessment is a lens that recognizes the role that trauma has in someone's life, and it also helps us understand how trauma can impact multiple domains of someone's functioning, including their physical and emotional well-being and interpersonal relationships with others in their life. A trauma-informed assessment requires a shift to ask our clients what happened to you, rather than asking what is wrong with you. And what this shift in framing does is it shifts from a deficits-based assessment to recognizing the inherent dignity and worth of individuals based on their experiences and not on their deficits. The National Child Traumatic Stress Network comprises trauma-informed assessment framework within three broad domains. So the first domain of the trauma-informed assessment framework is what I explained earlier, this information gathering process across multiple domains, verbally, non-verbally, and then with other systems for the client. The second domain is identifying and then planning to address the needs of children and families who are exposed to traumatic events, helping them identify what has been traumatic for them in the past that may be impacting their ability to function today. The third domain is the work of analyzing this information that we learn about the child and the family, summarizing that information, and then communicating this information to the child, family, and to other service providers. The National Child Traumatic Stress Network offers some different strategies that I wanted to share with you to help us engage in a trauma-informed assessment process. The first strategy is to clearly explain from the beginning to the child and caregiver any assessment tools or measures that we'll be using. So explaining to them what the SDQ is and how it can help. Allowing children to choose their language to complete the measure is oftentimes helpful and important for the assessment process. We will also want to think about how we can visualize aspects of our assessment tools. So things like dry erase boards can be really helpful to visually depict different aspects of functioning. Oftentimes when we're doing assessment, we're trying to measure the frequency or how often a symptom is occurring for a minor. So that's where a calendar could be particularly helpful, showing them from a visual perspective what we mean by a week, what we mean by a month. It's also helpful oftentimes to consider completing assessments over 1 to 3 sessions. This can be especially helpful if we're using assessments that measure certain sensitive aspects of a child's life, such as trauma. And then the final strategy is to remember that we want to be engaging in ongoing safety planning as necessary, especially if we learn that a minor's life may be in danger for reasons such as self-harm behavior or suicidal ideation, which are things that may emerge in the context of our assessment. There are some cross-cultural considerations that are unique to the population of unaccompanied children that we want to be aware of. For example, clinicians and other helpers for unaccompanied children, we will benefit from having specialized knowledge and understanding about history, traditions, values, and family systems as they relate to clinical practice with individuals, families, and groups. This is particularly helpful for unaccompanied children who are arriving to the US from some distinct cultural backgrounds. So we want to understand the history, traditions, and values of unaccompanied minors from Guatemala, how that might be distinct from unaccompanied children from Central America or Honduras. That will help inform the way we approach assessment and the way that we frame some of our questions. In addition, it's important to acknowledge that this population of immigrants arriving to the US is uniquely vulnerable to aspects of discrimination and systemic oppression. So clinicians should have awareness of how racism, sexism, ageism, heterosexism or homophobia, anti-Semitism, ethnocentrism, classism, and disability-based discrimination, how any and or all of these can negatively impact client mental and emotional well-being, as well as impede their access to treatment. And that's particularly important later on in the assessment process when we're looking at connecting individuals to resources. Okay, so we have a background of unaccompanied children, who they are, where they're migrating from, and the scope of this population in recent years. We've also gone over some key background information of assessment. So now what I'd like to do is offer some background on research on cross-cultural mental health and how assessment has been used in different parts of research. So I'm going to share with you one study that I wrote up with some colleagues that looked at profiles of trauma symptoms for unaccompanied children who had arrived in the US. This was looking at a sample of about 190 unaccompanied children. And what I was looking at was the DSM profile of symptoms for post-traumatic stress disorder. So I was looking specifically at symptoms of PTSD. And the main questions of this study were looking at, number one, what are the rates of PTSD for unaccompanied children in the US? How many of them are exhibiting symptoms that meet that criteria? And the second research question was a little bit different. We were trying to understand if the symptoms of PTSD that unaccompanied children were exhibiting, if that aligned with the diagnostic criteria from the DSM-5. So we know that the DSM-5 was written from a Western framework, from a US framework. We want to understand if that helps capture the unique needs and experiences of unaccompanied children from other contexts. So the DSM-5 has 4 profiles of PTSD symptoms: intrusion symptoms, avoidance symptoms, changes in cognition or mood, and then finally arousal and reactivity symptoms. So what we wanted to understand is, do the symptoms that they experience, do those align with those 4 clusters of symptoms? To engage in this research, the first thing that we did is we used the Child PTSD Symptom Scale. This is referred to as the CPSS. This is a measure with 20 items, and these 20 items are scored using Likert-style scoring, where it measures symptom frequency, particularly looking at the previous month of a child's life. And the Likert-style scoring is organized such that a 0 indicates that they are not experiencing the symptom at all, and then a 4 indicates that they are experiencing the symptom 6 or more times a week or almost always. So this is an example of where that visual aid, such as a calendar, comes in really handy when we're working with unaccompanied children with this type of assessment, and we want to measure symptom frequency across a specific time period. So the CPSS is designed to measure symptom severity for the previous month, and then the scores range from 0 to 80. A 0 indicates no PTSD symptomology, and the higher scores are indicative of greater PTSD symptom severity. Okay, so for that first research question, here's what we found for rates of PTSD for unaccompanied children. We looked at the overall sample, and what we found is that 8.1% of the overall sample met criteria for PTSD. So this was a little unique to us because we were expecting higher percentages of PTSD, especially given the amount of trauma that unaccompanied children experience on their way to the US. We also looked at country differences, and we focused on those 3 primary countries of origin: El Salvador, Guatemala, and Honduras. And what we found is that 9.8% of children from El Salvador exhibited criteria for PTSD. 10% of children from Guatemala exhibited criteria for PTSD. And then finally, 4.2% of children from Honduras met criteria for PTSD. So we know from this finding that substantially lower amounts of unaccompanied children from Honduras met criteria for PTSD, less than half than other children from El Salvador or Guatemala. But one thing to note is that we examined these differences and found that they were not statistically significant. However, we do think that there's clinical utility to these differences that we wanted to offer to you. So the second research question, looking at the symptoms of trauma that unaccompanied children are exhibiting, and do those line up with the DSM-5 profile? And here's what we found. We found that the symptoms of trauma that unaccompanied children exhibit, they map onto 3 different profiles. So the first profile includes all 4 of those clusters in the DSM-5: intrusion symptoms, avoidance symptoms, changes in cognition or mood, and then arousal and reactivity. So this is a very broad capturing of trauma symptoms. The second profile, the second profile includes 3 of those clusters. So intrusion, changes in cognition or mood, and then arousal or reactivity. So the only symptoms not included in the second profile were avoidance symptoms. The third profile only included arousal and reactivity symptoms. And this is what I want to focus in on with you for a couple additional minutes, because we found this particular finding quite interesting, and also possibly helpful for us in our work as clinicians and helpers. So that third profile of arousal and reactivity symptoms only included 2 out of the 20 items. The first measured how often an unaccompanied child gets angry easily, for example, yelling, hitting others, throwing things, so this more externalizing behavior. And the second item measured how often a child has trouble paying attention. This was really interesting to us because what this indicates is that these 2 specific aspects or symptoms of trauma are especially relevant for the experiences of unaccompanied children. These 2 specific arousal and reactivity symptoms are particularly salient to the experiences of unaccompanied children. So what we tried to do is we tried to make sense of these 2 symptoms. What do they mean? How can they help us in meeting the needs of unaccompanied children from an assessment perspective? And what we found is that it's important to place these trauma symptoms in context. What happens when children are having trouble paying attention and they're getting angry easily? Well, for unaccompanied children who have arrived to the US, it's important to understand that they're navigating all of these new norms and social contexts and expectations, and that this can be quite frustrating for them. So we thought about the context of school. So as unaccompanied children are navigating new norms in school, they're learning a new language, they're being exposed to new expectations that they may not readily understand. That, along with experiences of trauma, can lead to disrupted learning. So upon initial examination or observation of these symptoms, a teacher or other helper may think that an unaccompanied child is simply angry and not interested in school because they're not paying attention, when in fact, based on the findings of this study, those two specific behaviors could be representing unmasked trauma. So what we wrote in the paper is that this finding could be useful for school professionals such as teachers, guidance counselors, and social workers who work directly with unaccompanied youth. So where these behavioral outbursts could represent masked expressions of untreated trauma. So for those two symptoms, as I mentioned, difficulty paying attention and these behavioral anger outbursts, that's where we want to shift our thinking from not what's wrong with you, but we want to reframe that to what happened to you and how can I help you? How can I help you be successful in this setting? So that kind of leads me to this last component for my time with you today, and that's the Strengths and Difficulties Questionnaire. So what I'm going to do in this section of the webinar is I'm going to explain the main features of the SDQ, Strengths and Difficulties Questionnaire, what it is, how it's designed, what it includes, and then I'm going to show you some information on how to use it, on how we can apply it to our own work. So the Strengths and Difficulties Questionnaire is a brief behavioral screening questionnaire. There are multiple versions, one for 2 to 4-year-olds, one for 4 to 10-year-olds, 11 to 17-year-olds, and then there's also a version for individuals who are 18 years or older. It's been translated into more than 40 languages, including Spanish. It is used as a clinical assessment tool in a variety of health and mental health settings, including outpatient clinics, hospitals, and other health providers. It's also been used in research in over 5,300 studies and in 104 countries. It's one of the most widely used behavioral health measures in the world. Importantly, we also know that the SDQ has been used in contexts of research with unaccompanied children. So one study that I'll share with you on 166 unaccompanied minors in Belgium found that 29% reported emotional problems and 12.7% reported peer problems. In a separate study, this one was back in 2012, research on 71 unaccompanied minors in London found that 29.6% reported emotional problems and 23.1% reported peer problems, and then 50% reported hyperactivity problems. Each of those types of problems, emotional, peer, and hyperactivity, those are different parts of the SDQ that I'll explain in a minute. So what we know from how the SDQ has been used is that it's been mostly used in the context of Europe and the United Kingdom. So one really important new area of research is applying the SDQ in the context of the United States. Okay, so let's look at what the SDQ is, how it's designed, and then we'll get into how to use it. So it has 25 total items that measure different features of psychological functioning, and those are further divided into 5 separate subscales. Each of the subscales have 5 items, and that's what adds up to 25 total items. So there's one subscale that measures emotional problems, one subscale that measures conduct problems, one subscale that measures hyperactivity or inattention problems, and then the 4th subscale measures peer relationship problems. There is a 5th subscale, and this is a little bit separate because it measures prosocial behavior, and that's the strengths part of the Strengths and Difficulties Questionnaire. So what we do in terms of using the SDQ, you add the scores from the first four subscales: emotion, emotional conduct, hyperactivity, and peer problems. You add those together. That's based on 20 items, and then that total score is the difficulty score. The prosocial behavior subscale is a separate score. So it has relatively few items, 25 items. And what's also nice about it is it's very easy to implement. We're just trying to understand if something is not true, somewhat true, or certainly true. So it's a 3-point Likert style scale, really easy to implement and understand. And one quick note before I go on is the Strengths and Difficulties Questionnaire is measuring psychological attributes over the previous 6 months, and that's what we're looking for in particular. So what I'd like to do for a few minutes is go through each of the subscales. So I mentioned to you that there are 5 subscales, each with 5 items. This is looking at each of those subscales a little bit more deeply. So one thing you'll notice with the emotional problem subscale on the left-hand side is that the 5 items are spread out. So emotional problem subscale includes items 3, 8, 13, 16, and 24. This is the same for all of the other subscales. They're spread throughout the SDQ. And the reason for that is that it helps enhance the validity and reliability of the measure. So if all of the emotional problem subscale items, if all of them are clumped together, that might not measure emotional problems as accurately, rather than if they're spread out. So I won't read each of the items separately, but broadly what the emotional problem subscale is looking at is whether or not a child complains of things like headaches, or if they worry a lot, if they're unhappy, if they're nervous in new social situations, or if they're afraid, or if they're easily scared. And then you look underneath on the right-hand side, you look at if something is not true, somewhat true, or certainly true. So for each of these items, if something is not true, we score it as 0, and that means there's no difficulty. Remember that the lower scores are indicative of lower total difficulty. If something is certainly true, then that's going to be a 2, and that's indicative of the greatest amount of difficulty. So if we add up these scores, if every item gets a 2, then that would be a total difficulty score of 10, and the minimum, of course, would be 0. So this is the first subscale. I want to show you the other subscales because things get a little bit tricky with some of the other items. Let me show you what I mean. So this second subscale is interesting. It's measuring conduct. So here, what we're looking at as helpers, as clinicians, we're looking at whether or not a youth has temper tantrums. Do they lie? Are they obedient in the household? Do they get into fights with other children? Stealing from home, or stealing items at school. So looking at behavior for these children. One thing that I want to draw your attention to is item number 7. So I highlighted this because this is one of 5 items in the SDQ that is reverse scored. And here's what that means. Most of the time, the items are measured as 0, 1, or 2 for not true, somewhat true, or certainly true. But there are 5 items where if something is not true, it's a 2. What that means is that that's greatest difficulty. But if you look at item number 7, it makes sense. If you read the item and then you look at the logic of how it's asked, you'll see what I mean. So let's take a deeper look. Item number 7 asks whether or not a child is generally obedient. Now, if that was certainly true, they would get a 0 because that's indicative of no difficulty. We want children to be generally obedient. If it's not true, if a child is not generally obedient, that's where they would get the 2, indicating greatest difficulty. Now, the creators of the SDQ did this for 5 items, not to make our lives more difficult. Many behavioral health measures have items that are reverse scored. And the reason for that is it helps enhance the reliability and the validity of the scale. Sometimes you might get someone getting a survey and they just answer 0 for all of the items because they want to get it done quickly. This is one way to control for that. If you answer not true for every item on the SDQ, your difficulty score will not be 0. In fact, it will be 10 because there are 5 items that are reverse scored. So I can come back to this and explain it a little bit more deeply when we get to the question and answer period, but maybe we'll keep going and I'll explain the other subscales. Hyperactivity subscale. My teacher friends in the webinar, this one might be particularly helpful for you. So this behavior is looking at whether or not a child is restless or overactive, if they're easily distracted or if their concentration wanders, if they think things out before acting, if they are able to persevere and see tasks through to the end, if they're fidgeting or squirming. So a couple notes here. These are all symptoms that oftentimes emerge in school settings. So that's one thing that I would note. Not just school settings, but this is where teachers would see these hyperactivity symptoms. The second thing is that some of these items we can observe. Remember, with assessment, it's not just our conversation with a youth, but we're also observing if they're constantly fidgeting or squirming. The second thing I'll note is that there are 2 items on this subscale that are reverse scored. So item 21 and 25. You'll see there that item number 21 asks whether or not a child thinks things out before acting. So if that's not true, if they don't think things out before acting, that's not great. That indicates some degree of difficulty. That's why they would get a 2 for that item. And that indicates for us that they might need some help and some support. Similarly, item number 25, if a youth does not, or if it's not true that a youth sees tasks through to the end, then that would indicate some difficulty. So they would get a number 2 for not true. So 2 more subscales. The last problems subscale is peer problems. Friendships, they're so important and they're such an important protective factor for individuals who have experienced trauma. So this is looking at whether or not a youth is alone or if they play alone, if they're solitary. It measures whether or not they have at least one good friend, if they're generally liked by other children. It measures things like bullying. Interestingly, this item number 23, it asks whether or not it's true that a youth gets along better with adults than with other children. So these are the last 2 reverse scored items, item number 11 and 14. Those are reverse scored, so not true would get a number 2 for those 2 items. The last scale. I don't know if you're supposed to have favorite subscales, but this is probably one of my favorite subscales in the SDQ. It's measuring prosocial behavior. So I am a social worker by training, and the social work profession is looking at someone's lived experience from a place of their strengths first. And this is looking at the inherent strengths of unaccompanied children, of unaccompanied minors. These are items 1, 4, 9, 17, and 20. So these measure aspects of a child's life, such as whether or not they share, whether or not they're considerate of other people's feelings, if they're kind to other children, if they volunteer to help others around the house. I also like this subscale because nothing's reverse scored. So it's just very simply not true, somewhat true, or certainly true, 0, 1, and 2 in that order. The one difference with this subscale compared to the others, with this subscale, lower numbers are indicative of lower prosocial behavior. So unlike the other 4 subscales, we actually want higher numbers for this last subscale. So you complete the SDQ for a youth or for an unaccompanied minor, questions number 1 through 25. and then you score it using these subscales, these templates that I've shown you, and those are available in the notes as well, that are in the handout, excuse me. So these are also available in the handout. So then you add up all these numbers, and then you're left with, well, what the heck does this mean? What am I supposed to do with these numbers? And that's where these cut points can come in handy. There's been research that has shown that certain numbers mean certain things. So let's start at the top here. This is for one version of the SDQ that is designed for teachers. So there's a total difficulties score. And remember, that is for the first 4 subscales, not the prosocial scale. Just those first 4: emotional, conduct, hyperactivity, and peer problems subscales. You add up those numbers, and if a youth has a score of 8, that means they are close to average, which is about 80% of the population. So a total difficulty score of 8 is close to average, but then you see that if it's between 12 and 15, it is slightly raised. If it's between 16 and 18, it's high. And then if it's between 19 and 40, that indicates very high. So that's the most concerning. If you take a look at the subscales, emotional, conduct, hyperactivity, and peer problems, if you look at the close to average, slightly raised, and so forth, you'll see that they're slightly different. So if a youth scores a 5, for example, on hyperactivity, they're close to average. But take a look at emotional problems. If they score a 5 for emotional problems, that means they are in the high section, meaning they have quite a substantial degree of difficulty. So one thing that I recommend is starting with the total difficulty score, but then we really want to get scores for each of the different problem subscales. And the reason for that is that it can help us understand what types of referrals we should be making for unaccompanied children who have different types of problems. For example, it's very conceivable that an unaccompanied child could have very high emotional problems score, a very high conduct problem score, but then they might have a low hyperactivity and low peer problem score. So this really helps us understand different dimensions of their needs. So we've tried to find out using those cut points, if based on the scores, if the needs are close to average, slightly raised, high, or very high. And then here's what it means. If the youth has, if the unaccompanied child, if their score is close to average, that indicates that we need to continue to assess. We need to continue to learn about them, about their needs, about their hopes, their strengths. If it's slightly raised, we want to continue to assess, and then we want to plan for referral at discharge. If the unaccompanied child has high difficulty score, then that means we want to continue to assess, and we want to make sure that that referral is made prior to discharge. We want to make sure there's strong continuity of care and that the referral is made before the youth leaves our services. If the unaccompanied child or if the unaccompanied minor scores very high for total difficulties or for any of the subscales, that indicates that we need to plan for more immediate intervention. We need to refer to the appropriate services, and then we need to continue close monitoring and assessment. So let me offer you some ideas on what types of referrals might map up with some of these subscales. This is something that I'm really interested in, I think is so important when we're looking at using these standardized measures. One big takeaway for me, I'm in private practice part-time, and I've been in private practice for several years. What the SDQ can help us as clinicians and helpers, it can help us understand that not every youth needs the same services. So if you take a look here, if someone is exhibiting high difficulties for emotional problems, then individual therapy might be appropriate. If they're experiencing conduct problems, individual therapy might be helpful, but family therapy and in-home family therapy is also helpful. Hyperactivity scores or hyperactivity difficulty, that might emerge in school. So that's where we want to consult with teachers and perhaps access a special education assessment. And then finally, if an unaccompanied child is exhibiting high difficulties with peer problems, this is where a mentor might be really helpful, where organized sports leagues or different recreation programs in the community can help enhance a youth's social skills. Having those structured arrangements where unaccompanied children can practice making and keeping friends can be really beneficial. So this is just one brief referral guide to help you interpret the results of that SDQ. Let me conclude with a couple thoughts, and then I wanted to share with you one unique opportunity regarding this work. So number one, assessment. This is an information gathering process. It's part of our work as clinicians and helpers. The foundation of this process is the relationship that we have with an unaccompanied child. Unaccompanied children do exhibit unique profiles of trauma symptoms, and understanding this can help clarify their needs. And the example that I provided was looking at those two arousal and reactivity symptoms, and how those are particularly unique to the experiences of unaccompanied children. And then third, the Strengths and Difficulties Questionnaire. This is a behavioral health measure that can help us, that can help clarify an unaccompanied child's needs, their strengths, and it can also support the use of data-driven referral processes, and help us continue to engage in this work. Here are some references. These are also available in the handout. So this is the work that I use to support my ideas and to organize this webinar for you. And then finally, I wanted to let you know about an upcoming research opportunity. Some colleagues and I, Dr. Evans, who's supporting me today during question and answer period, we're looking at how immigrant families, as well as social service providers like you, how we've been doing during COVID-19 and how these challenges have impacted health, finances, as well as social support. In this study, what we're hoping to learn is more about social supports, challenges, and coping strategies that you've experienced in your own work during the COVID-19 pandemic. This study, we're collecting data using a survey. It takes about 20 minutes. And participating in this study, you're going to help researchers as well as social service providers in general strengthen services for immigrant families here in the US. It's also going to help us amplify the use of measures such as the SDQ and continue to adapt measures like that to the unique population of unaccompanied children. This link right here will take you to the survey. And again, it's about 20 minutes or so to complete that. I'd be really grateful if you'd consider it. And then if you have a phone that is smart, you can go ahead and scan that code on the bottom right, and that'll take you right to the survey as well. So I'll keep this up, and then maybe I'll wait a moment for my friend and colleague, Dr. Evans, to join me and help me parse through some of these interesting questions.
Yeah, great. Thanks, Rob. This was a wonderful presentation. There are a handful of questions, and so I tried to kind of group a couple of them together, and so I might read out loud more than one on the same topic so that you can address them together. So the first one's just looking for a little bit of kind of background on these kids. And so it says, what therapy is appropriate to provide within shelters? And for UC with PTSD diagnoses, are they being provided any mental health assistance?
What was the second part, Carrie, for UC?
With a PTSD diagnosis, are they being provided any mental health assistance? And I'm not entirely sure if that's related to the shelter or to the study specifically that you talked about.
Yeah, so this is great, and this is a wonderful question, and I will answer it this way. I don't like to punt questions, so to speak, but I will do a gentle plug. Christine a little bit later is going to do so as well. But I think it's next week. My colleague Rosera is going to be doing a webinar on that very topic. So I talked today about trauma-informed assessment, And Rosera is going to be talking about trauma-informed treatment. So what we are doing to actually engage in treatment with unaccompanied children. One thing I'll say is that there are treatments for unaccompanied children who are experiencing symptoms of trauma. One of them is a trauma-focused cognitive behavior therapy. Rosera next week will be speaking much more deeply about that. That's an intervention. I've been trained in trauma-focused CBT myself, but again, this is a tool, a therapeutic intervention that was designed here in the U.S. So it's really important that we understand how we can adapt this to meet the unique need of populations like unaccompanied children. So I would say stay tuned for Rosera's conversation next week in that webinar. But trauma-focused CBT is one way.
Great, thank you. The next one is also specific to the study that you did, and it's saying, perhaps I missed it. I'm wondering for the research, what kind of setting the SDQ was collected in. Was it a clinic, a school, private practice, or a resettlement agency? And with that, kind of which of the three versions was used in that study?
Oh, okay, great. Great question, and I'm sorry if I didn't clarify this. So I engaged in some research with the CPSS, the Child Post-Traumatic Symptom Scale, or the Child PTSD Symptom Scale. That research was with unaccompanied children receiving unaccompanied children in long-term foster care. I'm currently doing some research with the SDQ. I don't have specific data to share quite yet, but this study is going to be happening throughout the summer. And what we're looking at is implementing the SDQ with unaccompanied children who are receiving post-release services. So this is for unaccompanied children who are in resettlement communities receiving those case management services. Now, what I would like to see, I would love to see the SDQ used in shelters or in other settings where unaccompanied children are kind of immediately entering into the US, so that we can learn about their strengths and needs immediately upon their arrival, because sometimes long periods of time might elapse between arriving to the US but then arriving to their resettlement area. And there's a gap there, and I think that's a really important opportunity to use the SDQ.
Great, thank you. So the next question is, I'm curious about how the SDQ is used with unaccompanied children specifically, given the situation in which the informant is someone that has not been with the UC minor for a long period of time and may not know them well. Some of the questions seem culturally biased. They also go on to say some of the children are not used to being in school, have been sent here to work, issues with attachment in the home, and continued hypervigilance from the traumatic experience. So just kind of noting a handful of different ways in which they're concerned that the measure may not be appropriate. So I don't know if you could speak to that a little bit.
Yeah, I think that's a great point. I think that what we know from research on how the SDQ has been used with unaccompanied minors in other country contexts, such as parts of Europe and the UK, is that the data indicates that it can be helpful, and in that context. Here in the US, I think that's an important reason why we want to apply the SDQ and then learn how to adapt it. I agree that there are certain features of it that should be adapted, and gathering that data will help us understand what features to adapt and how to adapt them to meet the cultural considerations for this population. One thing that I mentioned about the SDQ and all these measures is that they are part but not whole of our assessment. So much of our assessment is directly with the youth with no standardized measures, but listening to them directly or speaking with their sponsors. So I hope just to emphasize that the SDQ can be part of this strategy, but we shouldn't be relying solely on it. And I think more research is needed to advance the adaptation of it for different populations.
Great, great. The next two questions are specific to schools. So do counselors or social workers use this screening tool within the school setting? And is there a national approach to train counselors in schools on assessing unaccompanied minors?
The first part cut out, Carrie, but did you ask, are teachers and counselors in schools using the SDQ?
Yeah, and I think it's also looking at like who should within the school setting. Should it be the counselor, the social worker, the teacher? Like who should be administering this assessment?
Love it. Love that question. Love that question. In terms of school, I think that this is a measure that's very appropriate for the school social worker or counselor. However, the creators of the SDQ created a version specifically for teachers. So I think that the teacher version can be adapted for use by clinicians. And I also think it's important to note that teachers can oftentimes have competing demands and competing needs. So I think that if the teacher's not available or able or doesn't have the bandwidth to complete the SDQ, it would be appropriate for social workers or counselors to complete it. In terms of a national approach, I'm not aware of one. And I think that promoting this kind of research and getting this knowledge and building this knowledge base can help different regions and different areas consider an approach for assessment.
Great. And we have 2 minutes left, so maybe one more question here. Actually, it looks like you may have gotten to all of them. Yeah, I think you've hit all of them.
Okay.
Actually,
Thanks,
no, wait,
Kara.
one just came in. Just came in at the last second. Okay. We are exploring the option of using the SDQ as part of our admission into our school system. If we were to administer the SDQ in our international office, would you advise school counselors following up with future assessments at the students' individual schools?
Yes. In fact, I think that's such a helpful question to end on. It's so important. If we administer, and this is what I'm doing with this research over the summer, is we're administering the SDQ at 2 time points. So I think it's incredibly helpful to administer the SDQ at 2 time points, one upon entry, and then a little bit later on when the student or the child is in a school setting. It depends on the context of the school in terms of how much later you would assess or implement the SDQ, but it's really important to assess at 2 different time points because that helps us understand how strengths and needs are changing over time. And all of that data can be helpful for us in providing services and support for the unaccompanied child. Just one quick example, they might have high emotional problem needs when they arrive. Those needs might go down over the course of 3 months, but other needs might arise. And that's why this tool can be helpful at 2 different time points.
Great, thanks so much, Rob. That's all the questions in the chat.
Yeah, thanks so much, Carrie. I think there's a couple other slides that Christine's going to help with. And I'm grateful for everyone's consideration of that research study that Dr. Evans and I are engaging in over the next few months. This is my colleague, Dr. Arango Agoya, who's coming up next on May 19th at 1 o'clock. And the title of Dr. Arango's webinar is Evidence-Based Trauma-Focused Interventions for Unaccompanied Minors. So a lot of what she'll be talking about is building directly on my talk today. And then I think Christine will go over the next few items here.
Yes, thank you so much, Dr. Hassan and Gary, for your excellent work. Here are some of the products that we have in our webpage for Hispanic Indigenous population. In the next slide, we have also products for unaccompanied children and families that are currently being published. I'm so sorry for the background noise. We also have our evaluation slide. Please fill the evaluation. It only takes a couple of minutes. You can scan the code with your smartphone, or you can click on the link that is in the chat box. You will receive a link after the webinar ends. So thank you so much for being here, and please log into the next webinar with Dr. Rosaura Orengo. Thank you so much.
Thanks, everyone. Have a great day.
Have a great day.